reason or other. They have worked out why, but again, we hit the ground running at 50-50, and then it just goes down, unfortunately, guys. from there on, as you probably noticed, by the time you get up to our ages, you probably find there seems to be more women around than there seems to be males. If they look at the statistics, show that by the time you get to 65, you're outnumbered by 25% by females. By the time you get to 85, you're 50%. So your chances of scoring as you get older get a lot better. Okay, so hang in there.
Except there's something else happens, I think.
Oh, well, that's it. There's other, but there's drugs for all of that. So we're all okay. So that's what happens. And in that period of growing up and going through these decades, and where the women certainly outlive us, there's certain times or periods during our 7 to 80 or 7 or 8 or 9 decades that we have here where we are particularly vulnerable. And as I said, birth obviously is one. Early childhood for males is definitely a lot worse than for females. Young males need family support a lot more than females. I don't know if you ever notice when you see some...
When you say early, what sort of...
Oh, I'm talking from literally, let's say, from 5-6 years of age until adulthood. That period, the formative years of growing up and going through puberty into early adulthood, males are far more vulnerable to family stress. They do like the knowledge that there's a mother and a father for them there far more than the females do. Yeah, if you look at, certainly from my practice, when there's an acrimonious split within families, it's the males that, the boys that tend to regress. The behaviour goes off at school a lot worse than the females. They tend to end up with the mothers with issues. Have they got attention deficit disorders? They need to see psychologists. And I would say probably they outnumber the females 2 to 1. The girls tend to handle it better for some reason or other. I don't know.
But you're saying this leads to them dying.
Oh, suicide rates. Yeah. Our suicide rates are far higher than females. If you look at males under the age of 30, if you took the suicide rates, we outnumber, for every one female suicide, there's 3 male suicides in that period of time. And another spike again for males in the 50s and 60s. There's this intense loneliness factor kicks in then for a lot of males, and that's when another dip in suicide rates, mainly among males, more so than females. So these are all reasons why we cull ourselves a lot more than the female population do, generally through more emotional issues. I don't know, but that's what certainly we see as a general practice coming through. It's the males that tend to, girls tend to talk more. Mums talk to the daughters a lot more. Fathers struggle talking to a son about things, emotional things, because the males tend to bottle up, and it's not cool to be emotional. It's sort of a trait of ours, this masculinity. It's called the paradox of masculinity. In our efforts to be masculine, we actually end up shooting ourselves in the foot because we don't actually show anything. Our emotions are not evident, particularly to like another male. So they bottle up, they don't talk about things, and then this is where the dramas come along. So that's not just the only reason why us males there's not as many of us as we get older compared to the female population.
Car accidents and big...
Oh yeah, well, there's more, we'll put it this way, there's more male suicides a year than the national death toll in Australia.
You mean the road toll?
Our road toll.
Yeah.
I mean, road toll. So that's how many male suicides there are a year. So
wow.
So it's quite a number. So it's just an important fact that a thing that we have to look at is the emotional side of things is actually an enormous thing, and becoming a lot more evident now as the years go on, more so than what we all talk about now: prostate, diabetes, skin cancers, bowel cancers. But this one now is moving up through the ranks as becoming more of a major issue because of not only of the fact that males are, shall we say, emotionally inept or have not been trained how to be emotional, as well as females have. And they've tried to work out why. Females talk a lot more when they're younger. Mothers talk to daughters a lot more. Girls go through the menarche. They go through menstrual cycles, so they learn, and then the women talk to them more. So there's that sisterhood that develops quickly to protect them. Then also with the fact that they've got changes in their body, they're more aware of their body than males are. We never. I mean, a male that's aware of his body or what's going on there before the age of 30 or 40 isn't heard of, you know, because we just do the male things. But girls are very aware of how they feel, the changes in their hormonal cycles make them aware of how they feel as a person, their changes, their external and internal changes, you know. So they're more in tune with themselves. So as a result, as they can read themselves a lot better if they're feeling down, if they're feeling anxious, if they're upset about something. You know, everybody says that the girls are more, they're always got these feelings, you know, where the blokes don't. But that's just one aspect of it all. And I mean, again, this is all becoming more and more evident with, probably now with divorce rates being about 50%. And that's not, it's not everybody wants us to blame the males and blame the females. It's got nothing to do with it. It's actually the change in this sort of socio-economic and political sort of arena that we live in nowadays, where I mean, the 60s revolution has completely changed the whole look of a relationship now. I mean, my father, when I was young, he used to say, you know, in the old days, men went out and, you know, got the bacon, and when he brought it home and the woman cooked the bacon, and he says, but now both bring home the bacon and they fight over who cooks the bacon, you know, and that was his line. And it's that internal struggle of, you know, it's more I know I don't want to get too deep into it or to sound negative, but I'm not. It's just the way it's changed, that this equality as such, which is gone. It's not equality, it's the fact that everybody wants the same role now, and everybody's now sort of juxtaposed for what the role is within a relationship, which just causes a lot of conflict. Does that make sense? You know, and you know, everybody's trying to accommodate the other person's feelings, and it all gets very difficult, because at the end of the day, men are very practical. We're born to be practical, and women are born to be very emotional and feeling and sensitive to other people's needs. And you know, as a result is, when you have to try and learn that other side and they're trying to learn your side, it all becomes very mixed up in the pot, and people get a bit confused about who's actually doing what. You know, like a meal, like I've heard people at work, you know, I have people coming in and they're not getting on, and the girl saying, oh, he just works all day, he doesn't love me anymore, you know, and then he'll come in and tell you, I'm working hard because we've got so many bills to pay. And he's seeing the practicality of it all, but seeing that he doesn't want to be there, he must be having an affair. It's, you know, it's a completely different look, and that's the problems. But anyway, we'll get off that train of thought for the time being. But so therefore, but anyway, as you grow up, as I said, as us males grow up, we run into this big problem called masculinity, where the girls go through their estrogen, males get their testosterone, and when that kicks in, that causes this problem area for males, because then we have to prove ourselves as being masculine. 100 years ago or 150 years ago, there was no bungee jumping, you know, there was no, you know, high speed car racing, you know, motorbike racing. There was none of these things. Men didn't have, the only probably outlook they probably had little things, you know, jousting in the medieval times, you know, or a little bit of maybe wrestling or stuff like that there. But nowadays you can kill yourself in 15 minutes now, well, just to prove your masculinity. That doesn't help us. That takes out a lot more males than it takes out the females. And they call it the paradox of masculinity. We do all this to show how strong we are. We all do these things that actually make us a lot worse. We actually end up breaking ourselves in the process. You know, dangerous behaviour, drinking, smoking or whatever. You know, I can take it, I'm a bloke, you know, I'll be fine. But unfortunately it's causing the opposite other effect. Women, compared to men, because they're sort of seen as they'd like to be married, maybe they want to have children, they want to look good, you know, they're all into their looks, so therefore they tend to diet, watch what they eat, don't tend to drink so much, smoke so much, whatever. The result is, because of the reason they want to be married and have kids or whatever, they actually do better looking after themselves physically compared to males. So we fall down at every hurdle in the process of moving up through the generations, where the girls are more in tune with, you know, just the general things to keep themselves, you know, it's survival for them. When you think about girls, they're looking at blokes and saying, well, you know, is he going to look after me when I'm going to spend maybe, you know, 4 or 5 years unable to work and having children? You know, so these things are going through their head. So there's a lot of survival things there, while males are thinking to themselves, oh, she's lovely, I'd like to just settle down and have kids, blah, blah, blah. And that's as far as it goes for him. But she's thinking about all these other things. Is he going to protect me? Can he financially support me? You know, are these the kids that I want to have with this person? You know, there's a lot more different thought processes, and that gets them through life a lot better, because they're more clued in than men are. Well, I used to when I lived in Belfast, all the girls used to go to these, we've got men's sheds now, luckily for blokes, which is great, where men can talk about things and fix things and whatever. And actually now you start realising that, you know, it's okay to say that you're feeling a bit down, or, you know, I've got a prostate problem, or my diabetes is playing up, and you can talk to somebody. But the girls in Ireland, they used to go and do like knitting classes together, and we used to call it the stitch and bitch class, where they could go and give it all about, and they get everything off the chest about what's going on around them. So those are the differences why girls basically make it through life a lot better than the blokes do, because what we've got is very damaging behaviour through, unfortunately, our friend testosterone. With testosterone, obviously, as you know, we've talked about, you get the bad behaviour, the dangerous behaviour, too much smoking, too much drinking. One good side of it is it tends to make guys exercise a lot more, because they do tend to, like, you know, you see the people going to the gym, they like to pump the iron, stuff like that. So that in itself has one good side of it, but unfortunately it does lead to an awful lot of reckless behaviour. If you look at have you heard of the Darwin Awards at all? If you look at it, if you look at all the cases of this people that have killed themselves through stupidity, and it's always blokes, you know, doing stupid things. Like I think I read one story where a guy had been bitten by a cobra, and he said to his mate, I'm a bloke, I'll be fine, let's go to the pub. And of course, a couple of hours later he keels over in the pub and dies after a couple of pints, because he thought, nah, it's only a bite from a cobra, I'll be fine, you know. It was that sort of attitude. So they're interesting to read, the stupid things that us blokes do. But in terms of, as we sort of go along on our merry way, you know, we go through those periods of, you know, growing up, you know, hopefully getting through the sort of emotional issues that we sometimes get thrown at us during life, but then we start getting hit with other problems due to a lot of environmental issues more than anything. The standard of food, as you probably know, is not as good as it used to be 20 or 30 years ago. We eat a lot more processed food. I mean 90% of people just go to Coles and get most of their food. And if you look at Coles, it's the only, you know, everything is at the right height to make sure you buy the wrong stuff. You know, you have to go really search out the good stuff, and the good stuff is always twice the price of, you know, the organic stuff is twice the price of the thing that's been sprayed to death with you know, Roundup and chemicals and whatever. So we fall victim to that. And with processed foods becomes a lot of problems, particularly number one would be obesity. And obesity in itself probably accounts for 70–80% of all our illnesses, our chronic illnesses, as we get older. I mean, they did a survey, like a normal BMI, a body mass index, is about 25. I would say for a normal man now would be about average 28 would be, and that would be now. That would be the average. I mean, there's very few that are in the normal range that I can find. And to get down to 25, it's quite hard, you know, but you probably tried, but the average one is about 28. The girls do better. Their BMIs are generally around the 25. And that's again due to obesity, and with obesity then comes the majority, probably 70–80% of all our chronic illnesses. I mean, diabetes obviously is a big one for us blokes. Testosterone deficiencies, androgen deficiencies are linked to obesity. Prostate cancer, bowel cancer, and then obviously smoke and alcohol account for other reasons for why we get sick. Now stop me if there's anything in here you'd want to talk to me about, you know, of any particular illnesses. I would say for men, the major probably would be ischemic heart disease, which is blockage of the arteries. And again, that comes with high cholesterol, salt, too much salt in your diet. I always love when people come in and say, but I never put any salt in my diet. But then we say, what do you buy? What do you eat? And you know, when they tell you the tins of things that they get, you realise, you know, have you looked how much salt, you know, is in those foods that you've bought? You know, you should really get everything fresh, as possibly fresh as you can. But again, all processed foods is just it's just a ticking time bomb for you. I mean, I don't know about you. I've got a tin of dog food from a dog. I mean, all I have to do is give one tin of that, and I can see the weight go on them. You know, and it says it's, you know, lean lamb and beef, but you know it's all the stuff that put in there with it. The other thing that we face nowadays, plastics, is which people don't know an awful lot about, but there's a thing called fifolates. It's a chemical they add to plastic to make the plastic harder or softer. All plastics, and so it's literally in anything you use nowadays have got these fifolates in it. So if you put a container in your microwave and you microwave it, and it's plastic, these things will get in your food. They're in your yogurts, all the tubes that make the milk and the yogurts. Whenever these plastics get fifolates, and fifolates, they actually mimic hormones in your blood, and can actually turn off certain hormones, like decrease your testosterone levels, and hence we're running into this big problem. That's not just the only reason, but it's one of the reasons why hormone levels are changing, particularly in males. We're running into now fertility issues. You've probably heard over this last 50, particularly, they say the sperm count in males have dropped by 50% in this last 50 years across the board, and now a lot of that has come down to, obviously, again, foods we eat, but these fifolates in plastics that get into your body and actually turn off your testosterone. They mimic your testosterone and mimic an estrogen, more like a female hormone, and that has the results of changing our hormonal chemistry, and have resulted in decreasing fertility for blokes. And then with decreasing fertility, decreasing testosterone, you run into problems then with things like erectile dysfunction. And then with that you run into problems with weight gains again, mood changes, mood swings, sweating, high blood pressure. It all comes with these hormonal changes that you come. So that's a big one that's coming to the fore at the moment. So infertility is a big one, and as I said, it's all changing now as a result. An awful lot of people are tending to move now to sperm banks as well for sperm, which is probably in the early days was a good idea, but I think that it's going to come back to bite everybody, in the sense that this manufactured, we live in this sort of disposable sort of society now that we didn't have 50 years ago. So you don't need a partner anymore. You can get the sperm from time. You can get good quality sperm, but you don't really know what you're getting, and you don't know. There's been terrible cases in America of the sperm in these sperm banks. Is just one doctor who's donated. He's obviously got the Donald Trump syndrome, and he's donated. He thought, I'll impregnate the world now, and he's got 50 siblings within 50 miles of his practice who don't know that they're half brothers and half sisters. So then you're going to run into all these genetic problems down the road if these people get together, sort of thing. So that's an issue there. If you look at diabetes as well, the incidence of diabetes is now just going up and up and up and up. I'm sure probably somebody has diabetes in the room. Again, genetic factors, it tends to run in families, but again, a lot of it's environmental in terms of our diet. Again, weight gain, high blood pressure, what else would be with the diabetes? Sedentary lifestyles. We're not exercising enough what we used to do, and with diabetes then comes all these other problems. We get chronic problems with our eyes, kidney failure, this peripheral vascular disease where we actually end up losing toes, and gangrene, which is a nasty one. And now the markets, if you look at the market, when I started medicine 30 years ago, there was 2 drugs. There was insulin, obviously, for people that needed insulin for diabetes, and there was probably 2 drugs to take orally for diabetes. But now the market, I can't keep up with the number of drugs. There's probably one coming out every year, a new one with this vast research, and it works in a completely different way to all the other 10 different classes of drugs that there are. So it's very hard to keep up with it, and that, if there's more and more drugs coming out, it means that the incidence of that disease is going up and up and up, because the pharmaceutical companies wouldn't be trying to make them unless there was a lot of money to be made in the process. So you always know when drug reps are telling me about this, you can be guaranteed that the incidence is going up in the community. They're always there. They're always there when hay fever starts. You'll see people, all the antihistamines and the nasal spray people will be in. And suddenly when you see all the diabetes people's coming through and through, you just know.
How do you know you've got diabetes?
Oh, how do you know? Oh, the symptoms of diabetes. Sorry, I should talk about that. Diabetes, probably for us, for our age group, it'll be picked up randomly in a blood test. You might go along and see your GP and he'll say, oh Mick, you're 55 now years now, you should get an annual blood check. And then probably 50, 60, 70% of them are picked up just from the fact that your blood test is high. You wouldn't have any symptoms. If you did come in with symptoms, there would generally be thirst, running to the toilet a lot, pass a lot of urine, sweating, weight loss you get with it as well, tiredness and fatigue, and those would be the sort of major 5 symptoms that you would get. So that would if you came into me and said, oh, I'm very thirsty and I run to the toilet a lot and I'm tired, the first thing I'd be thinking about is diabetes. Well, yeah. And if you told me your dad had diabetes and he had it when he developed it when he was 60 or something, I would say, well, it runs in your family then. So, and we just do a blood test and find out. Normal sugars are about generally under sort of, a fasting sugar should be under 5.5. So if you're coming back with fasting sugars above 5.5, it could be an indication you're diabetic or in the process of developing diabetes. So that's how we would diagnose it. It doesn't diagnose, for the complications of diabetes. It doesn't happen overnight. It takes 5 to 10 years, 15 years, and that's if people aren't looking after themselves. Majority of people do look after themselves pretty well, so with complications. If you do get diabetes when you're, in your 60s or 70s, the chances are if you look after yourself, it'll be something else that'll take you out. It won't be the diabetes. But if you don't look after yourself, 4 or 5 years of not looking after yourself, you'll be in trouble with diabetes. Prostate then is another big one for us guys. Prostate cancer is very rare before the age of 50. Probably only 1% of cases are before 50. Majority are over 60. But so we start screening about 50, which would mean you come in and you have a blood test done generally first of all, just like you get your sugar done. I do a set of blood tests for males. I've just got 7 or 8 blood tests that I do, which encompasses probably 80 or 90% of the sort of things we get. I can't do blood tests for skin checks for cancers, skin cancer. You have to go up and see dermatologists, and if you have any sort of spots you want looked at, you need skin checks. And I do advocate, if you're yachties and you've spent a lot of time outside and you've had a lot of sunburn in the past, you should be thinking about getting regular skin checks, every 2 years, depending on what the dermatologist thinks, And our rule of thumb is if you've got more than 200 dark moles in your body, you should be getting skin checks regularly every year, because it only takes one of them to change. The machines they use nowadays are great. They really map the spots out in your back and your front of your face, so they don't go around cutting out things that don't need to be cut out. They just look for changes over a period of 6 months or a year, 2 years, and then they decide then, whether they need to be removed or not. So that's that. For prostates, prostates are the instance that we always know about females and breast cancer, and it's always in the news about breast cancer or whatever, but the interesting fact is more males die of prostate cancer than females die of breast cancer. So that's just to let you know. That's because we don't tell anybody or it's not a big promotional sort of thing that seems to be on the, for breast cancer. So because we tend to, number one is it tends to be diagnosed a bit later, and you do see a lot of it in the 80s and certainly late 80s. But it does as I said, it does take more men out at the end of the day. Prostate cancer, if you were 85 years of age and I did a biopsy in your prostate, there's a 90% chance you have prostate cancer. It's just as you get older, you get it. But it all comes down to how ferocious or how vicious a cancer it is. If you're young, it can be a bit more aggressive. Hence the need to get it earlier. As you get older, it tends to be just not quite as aggressive. So, if you're diagnosed with prostate cancer and you're 75 or something, there's a good chance that, and it's early, the good chances you're going to be fine. So, how do you diagnose? Generally, again, like diabetes, majority now are turning up in the blood test. We do a blood test that's called a PSA, you've probably heard. And really what it's called prostatic specific antigen. It's a hormone that's produced by the prostate, and it's like, it's just like your liver. If you drink too much, your liver function tests get abnormal. Well, if you've got a cancerous tumor in your prostate, you just produce too much of this enzyme, and it's called PSA. But unfortunately, it's not ideal because it does go up with other illnesses. If you've got prostatitis, just an inflamed prostate. So if you had you know, if you're had a hard bike ride for a few hours where you're bouncing up and down in the saddle and it's banging against your prostate, and you came in to me the next day and it did your PSA, it'll probably be high, but it's not an indication of you've got prostate. It's just the fact that it's been traumatized, it's inflamed. So it's hard, you know, you have to sort of take it a wee bit with a pinch of salt and realise that, you know, it may not be prostate cancer. So if somebody says, your GP says to you your PSA is high, it doesn't invariably mean you've got prostate cancer. It means that it could be, but it could be a couple of other things as well. So hence, we do a rectal examination there to look for lumps on your prostate. And cancer, 60% of cancers you'll be able to feel them on the prostate, hence that's why the GP wants to do that. But again, if your PSA is elevated, generally we would send you off to a urologist who will make up a decision whether he'll do a thing called a biopsy. And it's not very pleasant, but has anybody ever had a prostatic biopsy? No? Have you? No?
Yeah.
Oh, right. You actually go up through the rectum, and it's there's 50 little, almost 50 little needles can go in and take little biopsies from your prostate, and then they look at it under a microscope and look at all the different tissue and just make sure that there's nothing cancerous there. So that's what they do. If it does come back as cancerous or something, but then, as I said, your options are, well, they need to go and do sometimes more scans, like an MRI scan, or give you your alternatives. If it does show cancer, you're looking at really an operation, either several types of operations. The most common one is a thing called a radical prostatectomy. That's where they go in there basically and remove your whole prostate. Hence the word radical, means you leave nothing behind. You probably heard about all the robotics with that one at the moment. A lot of people go up to the mainland. We haven't got it here at the moment. There's a couple of the urologists training to do it at the moment, but for some reason the success rates for recurrences are lower if you get it done robotically. And also there's the big drama with having your prostate removed is the fact that it cuts the nerve, the pudendal nerve, into your penis. So that causes erectile problems after, and that's the biggest side effect of a prostatectomy. You're left, you know, with an inability, or a lot of people are left with an inability to get an erection. Hence the robotics. The robotics are more, they can actually see the nerves. They the operation can be a little bit more nerve sparing. So there's a good chance that, you know, you may not encounter that problem. Hence a lot of the guys head up to the mainland, but they're very expensive. You need private insurance, and they're about $10,000 a pop for these operations. They're generally up in Brisbane and Sydney. They're doing them at the moment. But there's other things you can do. There's a thing called, a great thing that's come along now called, I think it's great, a brachytherapy, where they actually just, instead of removing your prostate, they just put these little beads in you which are radioactive. So it's like you get radiotherapy inside your prostate. So it goes in there and it just burns your prostate. At least you don't get an operation. They just pop them in there through a little procedure, cystoscopy. And the problem is with that, it causes an awful lot of scarring in your prostate. So down the track it's hard. If you'd end up needing a prostatectomy, it can be a bit difficult because there's a lot of scar tissue around there to get the prostate out. But a lot of people are going for that as well. So it means you don't have to go through any of this radical therapy, plus you won't lose your pudendal nerve as such, so you have a good chance that your erections will be intact as well. And you get an odd thing called retrograde ejaculation as well. Sometimes when you've had the operation of the prostate, if you ejaculate, it goes backwards into your bladder, so it causes a bit of confusion for people as well. It does. So it goes in the bladder, it goes the wrong direction. So that's another complication of it. And the other one is a bit of incontinence as well, where you can end up having just a difficulty sort of controlling your sphincter, your bladder sphincter, and as a result, as you can have up to maybe 50% of people after a prostatectomy can have sort of incontinence up to 50% of people have incontinence up to about 6 months after the operation. So hence the need for us blokes is, because there's a lot riding on it as such, it's very important to try and get it diagnosed early. And the earlier you get it, I have an awful lot of people that are just on this thing called active surveillance, which means that they've been diagnosed with a raised PSA, they've had maybe a biopsy and it's just shown maybe a little tiny bit of a cancer in the prostate, and the surgeons are just quite happy to watch it once a year, just keep an eye on the blood test and make sure everything's okay. They're just making sure it hasn't spread outside the prostate, because obviously it's like anything, once it gets outside the prostate, you get metastases and it goes to your bones. and you know that the treatment then it's all palliative after that. It's all just hormonal treatments that you have just to reduce your testosterone. Prostate cancer feeds off testosterone, so what you do is you reduce testosterone and you give these drugs, these injections that basically turn off testosterone in your body, so you don't have any, and that sort of stops the cancer's growing. Which isn't, but it has side effects again. People get a lot of flushing, facial flushing and stuff with these hormonal things that they get. And any questions on prostate issues that you're worried about at all? It's important. If you're over 50, as I said, you should be thinking about doing it every, if it's really normal, every 5 years. If it was raised a little bit, he should be thinking about doing it every year. Your PSA, just to make sure everything's okay. And that way he'll be well on top of things. If anything's going up and up and up and up, he'll get to the point where you'd say, yeah, I think a urologist should have a look at you. And if they get it nice and early, you're generally fine. It's the ones that present late that are problems. When you do start presenting with the other condition is, besides cancer, the prostate is just a benign enlargement, which is actually more common, which is just your prostate just swells. Us guys, our prostates just swell as we get older. They just get bigger. And as a result, is you've got the tube from your bladder going through your prostate out to your penis. So if it's growing, it's starting to squeeze in that tube, like on that apple. See your apple core, it's squeezing on it, and the more it squeezes on it, the harder it gets for you to go to the toilet, and pass urine. So you find you go there, you're dribbling, or you're really pushing to get a stream going. You're dribbling at the end. You feel that you're only left 10 minutes. You have to come back and go again because you didn't empty everything. And also you're up maybe 2, 3, 4 times during the night, going to the toilet, and those are symptoms suggestive of just benign enlargement of your prostate.
Is that when you have a TERP?
TERP, that's a TERP for that one. That wouldn't be a radical prostatectomy, that would be for cancer, but that's just a TERP, and they basically just bore a hole through, just widen the whole thing out so everything can get through. And but again, complications, nerve damage, incontinence, that type of thing from that type of operation. But there is medication for it. So I always people come in with these symptoms. I always say to them, like, you don't have to go for the bore just yet. We know it's not a cancer. We've done the blood test, we've done the rectal examination. We know it's just a benign thing. You can try medication, and there's medication you can take that just softens the prostate, and that's all it needs to do. It just makes the prostate a lot softer, so that means that the urine can get through it a lot easier, and that 50% of cases that'll settle your symptoms down. It will gradually get worse, but you might buy yourself 5 years or something with it, and certainly if it was me, I'd be going for that, and then wanting to get an operation where there could be complications. I'd like to leave it till it's a bit older, if possible, and that's called a TERP, which is just a bore. Sometimes they do it, they just, actually nowadays a lot of it's just lasered out, and now they've started a new procedure where they're just stenting, which is even better, so they're not actually causing any damage. They actually, like, you get a heart stent, you can get a prostate stent put in, so that'll probably be up and running in the next 5 years. I reckon you'll be hearing a lot more people getting stents, that sort of thing. It'll cause a lot less damage.
Can you get those independently? Like, can you get the cancer and the enlargement?
Oh yeah, you can have both. I mean, you do get both. A lot of people have had TERPs, and then what they do is when they do the TERP, they obviously get lots of bits of prostate coming out, but they send that off to the lab anyway, and sometimes they'll come back and say, hey, there's abnormal cells in here. So that situation, well, then you're into a different game. The surgeon may come back and say, like, we'll have to go further with this one, we'll probably have to do a radical prostatectomy. But yeah, it does happen.
I've got a couple of observations as to why people are finding it harder to live healthily. One is that you see all the cooking programs on TV.
Yeah.
They've all got sugar and cream and butter in them.
Yeah.
The main reason for that is that the suppliers of those products are sponsoring the programs.
Absolutely. Yeah.
And they will jump in wherever they can to stop anybody coming up with a counter idea, because they're after maintaining the product position.
Absolutely. I mean,
the other thing is, the manufacturers come up with healthy versions of things, or healthier versions of biscuits and drinks and spreads and so on, but the supermarkets never advertise them, they very seldom put them on special, and after about 5 or 6 years, they quickly take them off the shelves again, saying that there's not enough product share, not enough market share in those lines.
Yeah.
So we'll put something else up instead to fill the shelves.
Yeah.
And poor old Joe Blow, who goes along the shelves looking for the low salt, low sugar, low fat, everything else, suddenly finds that those products have disappeared.
Yeah.
And in order to eat something of a varied diet, they're forced to buy something they don't really want.
Yeah, no, absolutely true. I mean, it's there's money in fattening people up. You know, I feel always said that we're like we've been fattened up by veal all the time. You wonder sometimes. I mean, profits are put far above people's health, and this idea that
I think it's time that there'd be some regulation of the market and say, if you're going to put a product on the market, you're also going to put up a healthy version of the same thing.
Yeah.
And it's going to be advertised alongside the main product.
Well, that'd be a great idea. And I think you get a lot of people on board with that suggestion, you know. But
because it's driving the overload of the hospitals, it's driving everything.
But I mean, to take it for example, I mean, just hospital food itself. I mean, I don't know if you've ever been a patient in the hospital and you see what you get, you know, and you realise, I mean, it is unhealthy. I mean, even the hospital food is unhealthy because they have to keep doing. It's all about, you know, what we can get, what's the best bargain of stuff we can get. A lot of it's processed, a lot of it's tinned, everything, you know. It's very sad. I mean, that's the way it is. I mean, you really do have to struggle now to find, you know, good, healthy food in a supermarket, you know. And as I said, it's not put there, and it's twice the prices, everything of all the other rubbish, you know. I'll never forget I went to Disneyland with my kids about, I don't know, 10 years ago. I went into Disneyland to get something, I don't know what I got, but I asked for, I needed the one. I think my son said, "Oh, can I have a Coke?" And I got him a Coke, and I said, "Can I get a water?" And I got a water, and the water was with that size, and it was like $5. And then the Coke was that size, and it was $2. You know, and you're going, how is that justifiable? Because there's 20 times more water in that, you know. But it's just, you know, they got you with the sugars and whatever, and you know, it was disgusting, you know.
There's a lot of sausage manufacturers who believe, rightly or wrongly, that the fat content of a sausage must be a certain figure. They've never cottoned onto the idea that you can make a sausage without fat. Or even low fat. They just don't want to know. They think, oh, it's got to be 35% fat by government regulation. Absolute poppycock.
But then again, some of those fats on meats your body needs.
Oh yeah, no, there's certain, there are fats. I mean, fats. I mean, fats. But somebody said to me, eat fat or eat sugar. I eat fat. It's at the end of the day, it in the long run would be better for you to eat. Sugar's a killer. I mean, it's just notorious now. It's just a silent killer now. I mean, you look at like a can of Coke has got 17 spoonfuls of sugar in it. I mean, you think could you imagine you putting dissolving 17 spoonfuls of sugar in a glass of water and drinking it? You wouldn't do it. Dream of it. You buy a tin of Coke and you wouldn't think twice. You know.
When was the last time you bought a loaf of bread yourself?
For myself, I bought a loaf of bread last week. Yeah.
Did you take account of the thickness of the slices?
I didn't know. Didn't.
Here in Tasmania, there are now two slice sizes that are common on the shelves. One is what they call sandwich, and one is what they call toast.
Yeah, well, yeah. I've heard that. Yeah.
But if you remember what was, if you were here 30 years ago, 40 years ago, the thickness of the slice of the bread was one size fits all, and it was all sandwich style, and it was half what they now sell as sandwich, and we never had anything approaching the toast category that we've got now. The manufacturers of the sliced bread have said, oh, we can sell more loaves if people want 4 slices of bread for their lunch or their breakfast or whatever. We'll give them the equivalent of what they used to get in 6 slices in 4, and we'll sell more bread.
That's what it all comes out. It all comes out of
But
profits.
I've asked around, why have we got such thick slices? Oh, nobody knows apart from that's what the manufacturers supply.
Yeah, I know. There's always there'll be method in the madness always, and it'll always be. It always comes down to following the money, doesn't it? And who's making the money out of the whole thing, and we're the suckers with.
You always try making it because I make my own.
Well, that's the other thing, you know. I do see the odd person with the bread makers. I think that's great. I try to go down to the farmers market and get my bread down there, because I just think at the end of the day, it's possibly but a bit healthier.
Buy a slice, cut it what you want.
Yeah, exactly. That's right.
We used to make our own bread. We had two bread makers, one at the shack and one at home.
Yeah.
And we had to give up because we could not find a source of a 5 kilo bag of granary flour. It was all 12.5 kilos.
Yeah.
And if you try and use 12.5 kilos in the average family, you won't get to the end of it before it goes off.
Right. Okay.
It just loses its impact, and you end up with a crummy loaf.
Right.
Pardon the pun. But we've now just managed to find one retailer who supplies the 5 kilo bags.
Yeah.
How old they are, we don't know. We're still trying to work that one out. But if you go to the major supermarkets, well, for a start, they don't carry the bread flour in bulk bags anymore. It's all little 1 kilo bags, which puts the cost way up. If you go to the wholesalers or the cash and carries and look for a 5 kilo bag, no, 5 kilo plain, 5 kilo wholemeal, granary, no, 12.5 kilos, thank you. Again, you just can't use that quantity of flour in the time that it's got a shelf life on.
Yeah.
So everything's again you.
And particularly fast food as well, which has been, you know, like McDonald's and Kentucky Fries and whatever it is, which, well, my children, KFC is the kids' fattening centre, we call it, you know. And but there was a case in America, but Jimmy Oliver, who you all know, you know, we did all the cookery programs. He went to, I don't know if you saw the program where he went to America, and he went around all the American schools, and he couldn't believe what they were eating. You know, the kids were just giving chips and pizza, and he was like saying, "This is insanity," you know. And he ended up then going to investigate, got patties from McDonald's, and actually got them analysed, and he found that it was actually it was meat that was actually not fit for human consumption. That they were serving in the meat, and they'd actually dyed it to make it look red, and they'd put sodium hydroxide to make it softer, and they chemicalized it and done everything, and these kids were all eating this stuff, and he took them to court, and he won, you know, in America in the court of law, that, you know, it was substandard meat and what they were doing, the processes were wrong. But of course, what did it do? I mean, the companies probably, you know yourself, a big company, so where if you don't pay one of your tax bills, you probably end up in prison. These guys defraud the general public of $1 million, and they get suspended from being a CEO of a company for 6 months. You know, it's because it's all big money, you know, and they're seen as too big to
and the American market has got a lot to answer for when it comes to supply of meat. For one thing, they go through what they call ground meat, like it's running out of fashion. If they get a steak, it's so marbled that it's full of fat, and you can't eat it honestly as a steak. It's just clogged together mincemeat with everything thrown into it, which you don't get a chance to trim the fat off the outside. It's all through the meat. And they're pushing that as being the healthy, tasty way to go, but it's not the. We're going to come undone in another 10 years.
Well, there's going to be, you know, it's like in medicine, we you know, particularly with drugs, I'm always really wary of new drugs to come on the market, because, you know, how well tested are they nowadays compared to, let's say, 30 or 40 years ago. I don't think they probably are as well, the controlled trials have been performed as well, because it is a big pharmaceutical company, and I hate to say it, you're trying to, you know, sell things that, you know, they probably, if things go wrong, they'll wangle the way out of it in the court of law, you know.
Change your name. Change your name and keep going.
Change your name and keep going, yeah, and change it, or sell it if it's getting bad press in one country, sell it in a different country before they find out that it's that it's got bad press. There'll always be a third world country that'll take it, you know, which is very sad. I mean, I went like the days of like, you know, drugs like thalidomide, and remember the Vioxx that we had there not so long ago, 15, 20 years ago for arthritis, and it was causing heart attacks and strokes and God knows what, how these things got through. Yeah, but a big part, but these companies are still going, you know. They didn't shut the doors, you know. Well, that's it, you know. And so it is, and that's why diet is so important. Now, I do say as time goes on that the diet is the #1 thing that needs to be addressed. Absolutely. I mean, you know, all the things, the processed foods, the fast food bars, they just all have to be just completely ignored, you know.
I guess if you live on your own and you got to have 5 vegetables every day,
and your 2 fruits as well.
And that's right. My solution is to buy these frozen packets which have about 5 different vegetables in.
Yeah.
Now, is that sensible or not?
I can't see anything wrong with that at all. You know, I mean, it's. I mean, if it's not, I would just say if it's in a tin, you know, don't eat it. You know, it's. I mean, there's going to be additives or whatever and preservatives.
But just the packets of.
You just send like a dry vacuum pack sort of.
Yeah.
I can't see anything wrong with that. You know,
I did some studies on that because my partner's gone away for a year, and I'm going, how am I going to cope?
You've got the same
right,
problem.
so I do, but for a long time, we don't eat any bread, any rice, any pasta, anything in a packet.
Yeah.
So, you know, I know I've got my larder sorted out correctly when on a Saturday night I've got the munchies and I stand for 5 minutes in front of the cupboards and I can't do anything because there's nothing bad in there to grab. So we did a study on that frozen vegetables. They said that these days the flash frozen stuff is not too bad.
Yeah.
And you know, that's pretty easy. But I take your point on the microwave, or on the plastics in the microwave.
Yes.
You know, I think I'm switching to glass. How many of us put our stuff in plastic? You know, and don't think about it. I didn't know about that.
Yeah, no, it's bad. Plastic's going to be. I think they're called phthalates, and they have. It's been well proven now that they're a major problem. You know, but you know, I was very interested. If you look at the list of causes of, let's say, low testosterone, it'll start off. It'll be genetic, and then it'll say it's lifestyle or obesity or smoking, or high blood pressure, and then eventually so environmental factors. And they won't specify very well what they are. Just say
they want to get sued.
They want to get sued, so they just say environmental factors, chemicals within the environment or something, and then it'll be well down the list, you know. But it's there, but they know it's causing these sort of issues and stuff like that. So plastic will be. It seems to be. It's going to be a major health issue, you know. And in fact, things not only that with other conditions, you know, it'll probably come out. Plastics, you know. I think they analysed. In America, they basically they analysed the urine of I don't know how many people. 100% had these. 100% of the population had these phthalates in their urine. You know, so it was totally widespread.
And the crazy thing is that there are communities in the European area that have diets far worse than ours, and they use olive oil and all sorts of bits and pieces, and yet their cardiovascular problems are way below ours.
Well, as I said, if you look at Japan's got a very high incidence of smoking, but a very low incidence of heart disease, and it's because of all the fish oils, because they eat, you know, not so much now, but certainly 10, 15, 20 years ago they were eating an awful lot more fish, and they put it down to us the protective factor of the omega fish oils.
So there's something else we're doing wrong as well.
And the Mediterrananean diets, as you said, the olive oil, the natural olive oils, the Mediterranean diets have always been, you said, as you know, extremely healthy, a dietary nature, you know.
You mentioned before, you were saying about how men being masculine and you know, bottling up things. Do you tend to find that you've got more patients talking about their physical health or their mental health? Which one seems to be the most, you know, the most problematic for men?
Certainly, men. I would say, interesting. I get a lot of men that come into me, and they will open the opening or their opening statement will be, "I wouldn't normally be here, but my partner or my wife demands that I must talk to you about this, because I'm embarrassed to talk about, and it'll be something that is very, very normal to talk about. Whether well, not that situation, not generally psychological, but it'll be about a skin lesion. Oh, there's a spot in my back, and I'm sure it's nothing. But my wife says, or she's noticing that I'm snoring a lot, and she's worried about sleep apnea. Whatever. But I think I'm fine. I feel good. Whatever. But in terms of the psychological side of things, but I'll be honest with you, and I've talked about a lot of doctors, and the general agreement is that probably 50% of our consultations, whether it's male or female, is stress related. At least 50%. When you boil it all down, and you distill it down, it'll come down to when you. And unfortunately, sometimes it'll be quite a long time to get there, because it'll come in with somebody say, I'm extremely tired, and my father's, there's a family history of lymphoma or leukemia, so you're off down the track still thinking it could be a hematological disorder, and then you go down this track, it could be, no, I've got a sore throat, it could be glandular, and then eventually you're doing all the tests, this, and you get whittled down, you're going, how's things at home, we're going through these financial issues, and then you realise once you start talking about it, they start feeling better. And it's presenting, somatic symptoms are presenting an awful lot more. Men present somatically, as in physical symptoms. The majority of men will present, when it's stress, they'll come in with, chest pain, they'll come in with stomach cramps, diarrhea, neck pain. It'll be these sort of symptoms that suggest, when you're well done, it is stress, but it's presented with spasms, or generally spasms in the muscles, or too much acid in the stomach, peptic ulcer symptoms, that type of stuff. Headaches, migraines, that things. Girls tend to come in and just sort of say it as it is, I'm really feeling stressed at the moment, they see it for what it is. And but men are getting better at it. I think it might be the kids are the sort of environment we live in now, that there's an awful lot more psychologists in the environment now compared to when it was 10 or 15. Even when I arrived over 20 years ago, there was very few psychologists about, outside the odd school psychologist. There wasn't, somebody I could refer to willy-nilly, or now there's, if you go in the phone book for, or not phone book for you, but for my medical director, if I look at it, there's probably 100 psychologists, maybe 150 in Hobart. There's no shortage of psychologists, and they've got these things called mental health care plans now, where you can go to and because a psychologist can cost $150 to talk to an hour, and not an awful lot of people have that. You'll get a bit of rebate from Medicare, but it won't be $150 you'll get back. But they've done these things called, the government, which is a lovely thing they've done, they've introduced this thing called mental health care plans, where if your doctor does this thing, it's just a lot of paperwork, but if he does it and presents it to you, that gives you up to 10 visits with a psychologist, like half the price. And so it's made it very affordable, so everybody sort of knows about them, and they come in, particularly with the kids and stuff, and young adults now. I'm getting a lot more young fellas coming through, sort of 14, 15, 16 at school. I didn't see that 15 years ago, 20 years ago, but I see a lot of them coming through now. I would see 1 or 2 a week coming through, who going for mental health care plans because they're having problems with bullying at school now, or personal identity problems, or family issues that they can't talk about, whatever. And the parents are generally very good now, because they come in and say, look, he's having problems talking to us, maybe it'd be better if he talked to a third party, which is really good. And they get the ball rolling. Once they get talking, they're fine.
It's interesting because you talked about the suicide rates and things like that. There's just so many, there's mental health days, there's Are You OK Day, all these sort of things that seem to help a little bit, but there still seems to be that block that a lot of men just seem to, even talking to their mates, they don't like to discuss these sort of things. Yeah,
well,
it's quite interesting.
The sort of Are You OK Day is great. When I always compare it to, when you're travelling abroad and you're trying to take your foreign phrase book with you, so you go into the shop and you ask for a croissant, and you ask for a croissant, but you're not prepared for the answer. So it's like, are you okay? And if somebody says, I'm not okay, you don't know what to do in that situation. So there's a standoff of embarrassment again, So are you any further on with this one,
You were talking earlier about the men's shed movement and so on.
Yeah.
With the women's craft groups and so on, their work is usually done in silence, So it gives them a chance to talk while they work.
Yeah.
Men's sheds and so on, there's an awful lot of machinery noise going on.
Right, okay.
And most of the guys with the machines are using headphones, earmuffs, or should be.
Right.
Those that are outside doing other bits and pieces are often working on their own. When they come round for a cuppa, I've noticed that only a couple of the men's sheds in an area will be open to talking about men's health problems and things like
Right,
that.
okay.
Others shut up shop about it. They
Yeah.
might joke about men's health,
Yeah.
but they won't talk about it.
Yeah.
And there's still a lot of work to be done. Those guys are in their 60s and 70s and 80s, and for them it's still a taboo subject.
To talk about, yeah. I mean, it's that old stiff upper lip, you know, that came through maybe through sort of that sort of colonial British sort of idea, you know, and like children are urged to be seen and not heard, and all that that sort of stuff, and this sort of, you know, people coming back from the wars with, you know, mental health issues were, you know, looked on as pariahs, you know, you should have come back as a hero and not have this, you know, shell shock syndrome and stuff, which has caused a problem. I used to have theories about, you know, things like, you know, people that have got decorated, heavily decorated in wars, you know, they've gone into machine gun bunkers single-handedly and taken on, you know, 5 Germans, but get killed in the process and get awarded, you know, medals of valor. But they were probably suicidal, you know, and they thought, well, I'm so suicidal and I'm so mentally gone now from this war that at least if I go out in a blaze of bullets, you know, I know I'm going to die, at least the family will look at me as a war hero, you know. But he was probably somebody who came home, he wouldn't have been fit to do anything, you know. You don't know, was that the rationale for a lot of those people, you know, and they did it? I don't know. But I remember reading a theory about these sort of things. But yeah, but really for us men, just things to think about is, as we over 50, as I said, things you got to worry about. It's always the same, said the usual suspects. It's going to be skin cancers from the outside. Then you're looking at diabetes, heart disease, bowel cancer, testicular cancer, and prostatic cancer, and then generally lung problems, generally through smoking, COPD, lung cancer, emphysema type thing. And that's sort of, when anybody comes into me, when somebody says, oh, I'm a bloke, I'm 60 now and I just want a bit of a check, those are the things that I just want to, all the questions will revolve around those sort of 7 things as to what it is. And I mean, and the majority, as I said, it all is, you know, it's age, it's smoking, it's alcohol, it's, as I said, diet, too much sugar in your diet, high blood pressure, I forgot to mention. Your high red meat in your diet predisposes as well to things like bowel cancer. You know the checks, do you get those in the kit? Do you the kits in the post every 2 years? And you do your FOBs and you do that. Well, it's just a screening test for bowel cancer, really, because...
Yeah, I deliberately put blood in when they come back negative. So
you seriously, yeah?
Waste of time.
You did that, honestly?
Yeah.
And it came back negative?
Yep.
That's incredible.
I got a colonoscopy done instead. A colonoscopy, I got them on in done.
Yeah, instead?
Yeah,
did you have a family history or something that they...
My grandfather got it. Yeah,
you
I thought I'd rather do that. So at least you're out cold and.
Well, I mean,
that was fine.
Was that like a private thing you got done? Yeah, because if I sent you publicly to the Royal and said you just want to do it, well, you'll be dead.
You do it first.
You'll die first before you get it done. They won't do it unless you're done.
In terms of blood pressure, can you talk about which is the important one, the top one or the bottom one, and the variability?
All right, okay.
You know,
yeah, I mean, blood pressure is arbitrary because it's subjective as well. Because you come into me, I would say every blood pressure that sits down, I always look at it and go, it's not your blood pressure, you know, because everybody comes in and it's up. Because
it's a white coat.
It's a way because you're worried. I mean, you're anxious. Oh my God, my blood pressure. As soon as you say, well, blood pressure is going to go up, it goes up. You know, as soon as you start stressing about it, so I'm going to say to you, look, it's probably going to be up, but we'll just see how high it is. You know, if it's sitting there at 250, you know, I know, like that's not just anxiety. You've got blood pressure issues, but if it's sitting there and you come in and you've got, you know, a normal blood pressure, the top end should be under for our age group. You know, it depends on your age, but let's say for our over 50s or whatever, it should be less than 140. The top end. The bottom end, you try to get less than 90. Okay. Now, which of those two is the most important? The bottom one. Okay. The bottom one, because that is your resting. That is when your heart contracts, it forces blood out into your circulation. So that is the rise in the blood pressure. That's the top blood pressure. When it contracts, your blood pressure goes up because it's just squirted, 100, 150 mils of blood into your system, so your blood pressure goes up. But it's just a quick spike, so it goes like that and then it falls down again. So that's your top blood pressure. So it doesn't do any real damage. All it does is make the artery go like that and then again, and out and in to take the pressure of it. But that resting one, when your heart's relaxing and filling, your blood pressure never drops. It's the one that never drops below. So that's your resting pressure. It's called your diastolic, and it's your resting pressure in your arteries, and that's the one that has to be down. If it's high, it means that your arteries are constantly under pressure. And
if sometimes it's 110,
yeah, 110 is too high,
and sometimes it's down at 60.
Yeah,
what's that mean?
We would just call that a labile blood pressure. If it's up at 90, again, from day to day, I do a thing called. Has anybody ever had a 24-hour ambulatory blood pressure done? So if you come into me and your blood pressure is sort of all over the place, and I'm doing it and it's going up 10 points or 15 millimeters in 2 minutes, I say, look, it's hard for me to tell if you've got a blood pressure issue. I'm going to send you for a thing called the 24-hour ambulatory BP. So I send you down to the Hobart Heart Centre. They fix this cuff on your arm. You go at 10 in the morning, they pop the cuff on your arm. It's a wee machine you wear on your belt or on your side, and this unfortunately inflates every 15 minutes for the next 24 hours and reads your blood pressure, no matter what you're doing, whether you're driving the car, whether you're at work, whether you're sitting eating your dinner, watching the TV, sleep. And then I get a graph, you go back in, they take the cuff off and they plug this machine into a computer, and it gives you it'll give me then, so if it's 24 hours and every 15 minutes, so 24 hours times 4 more readings, and then it plots it all in a graph for me, and then you come back to me and I'll go through the whole thing with you, and it'll let me know, really it'll work out the average blood pressure for you, the top average, the bottom average, and your average pulse and everything, and that gives me an idea really where you are. And then it's going to be, and it's very interesting, when you sleep your blood pressure drops, and it's amazing. So it just goes, so the graph generally goes like this here, and then when you go, it's 10 o'clock at night, it just goes, and it just says, and then it goes 7 in the morning, and it goes back up again. So your blood pressure naturally drops when you're fast asleep, and then when you're up and doing things, stressed, thinking, moving about, she goes up again. So it gives me the whole average, and then I'll work out from that if you've got a blood pressure issue from your averages of the whole time. So it doesn't matter if it's jumping up and down the circuit.
You talked about the maximum for the diastolic. Is there a minimum that you should have?
A minimum, yeah. Minimum for the diastolic. You do see it. Theoretically, we don't worry about it. I've seen diastolics. People sit with diastolics at 50, and generally that happens in people that have got valve problems in their heart. Generally, a thing called regurgitation. And what happens is when your heart squirts out the blood, the valves, and when the heart fills, the valves are only one-way valves, so it keeps up pressure. But if they aren't, if they've got like a cusp that's not working properly, this water's the heart's almost like squirting both directions, and you get these massive drops down the blood pressure. It can actually drop in the system, but it doesn't seem to cause anybody any problem. As long as the average is sitting between the 140s and if it's 140/50, the average is going to be around 100 or something, so they'll be fine. It doesn't cause any issues that I can see, or have had any issues with it. So all we really worry about, there's no treatment for low blood pressure. There isn't a drug we give anybody. If you come in and you've got low blood pressure, really it's a matter of just taking your time. Don't get yourself in situations when you're very hot. Don't lie in a hot bath for half an hour and get vasodilated and then stand up. And you're taking your time getting out of bed or up from the toilet, this sort of thing. But we only really worry about high blood pressure.
I've got a reason for asking this. Do many people of our sort of age present with anaphylaxis?
Interesting question. Anaphylaxis is on the rise. In the SAS 30, every second, third person I seem to see coming through seems to have some sort of allergy, a peanut allergy, or like a prawn allergy or whatever. I don't understand where this is coming from, because it wasn't around 30 years ago. Again, I start wondering, is it it has to be something, how we're ingesting something or whatever we're getting into our bodies.
Reaction to the plastics.
Well, I mean, it'll be 50 years from now, we'll probably have all these answers to these questions, but certainly it's something that's highly on the rise. If you look at now, there's so many doctors do allergy specialists now. I've got 2 GP friends that have branched out into it, and their books are full with people getting allergy tests, and my daughter's got allergies. And I mean, I just think it's going up and up and up. In the elderly, and not elderly, but later in life, it's possible. I mean, you can develop an allergy at any stage in your life. There's nothing to say no.
Do many people present with jack jumper?
Yeah, there's a lot of jack jumper. Yeah. I had a great one where a lady, she's a patient of mine, and she lives out down Dunalley Way, and she's highly allergic to jack jumpers, and she went out, she lives on her own, and she went out to get something outside, and when she was reaching down around the side of the house to grab something, jack jumper got her. And she realised, she said, and she knew what was going to happen, and she just had time. She said, all I remember was running into the house, lifting the phone, dialing the ambulance, and she said, I do not remember anything else until I was in the hospital. And the ambulance said they arrived, and there she was on the floor with the phone off the hook, and luckily she had managed to get her dress out, and only for that she would never
live at Orford, and I've had about 20 ambulance trips from Orford.
Yeah.
And I went on the program, the Jack Jumper experiment they did in 2001.
Is this at the Royal Clinic? Is this down at the Royal?
Yeah.
The clinic, yeah.
And just so happened I was the first patient on the first day, and it was so successful they had a double-blind test. They had to stop the test because the reactions from the people who were on the placebo was so dramatic in some cases, and it was 100% positive. So that's something that has turned it around for many, and we're talking hundreds and hundreds of people.
Yeah, that's wonderful. But it is a common anaphylactic allergy. That is. I mean, the jack jumper clinic's been going for a long time, and they've been an awful lot. I'd be sending 1 or 2 people down a year to that one. So it is a problem. Allergies are a problem. All round allergies. Unusual. I don't know. I don't understand where they're coming from. But there will be invariably 20 or 30 years from now. I don't know what's going on. Luckily enough, they do these desensitization programs now, as you know, and they do for an awful lot of other things. And I don't know if you do suffer chronic sinusitis, particularly certain times of the year, if it's grass pollen or dust or certain types of molds or whatever. They can do these little injections you get every week for a few weeks and then every month, and that just actually desensitizes you to your allergies, and they seem to be very successful. So that's always something to keep in mind. Is there anything else you wanted to talk about in terms of men's health? Any particular things? Angina, cardiac disease? Is that something anybody's worried about at all? Or,
Might do a lot of atrial fib.
Yeah, atrial fibrillation. Yeah, it's common. Yeah, very common. Atrial fibrillation is an irregular heartbeat, and it's generally caused because it's a little electrical disturbance at the top of the heart. I suppose you call it like heart epilepsy as such. It's not brain epilepsy, and as a result there's different forms of treatment for it. As you do, people that tend to get it sometimes associated with heavy alcohol, heavy tobacco. It has an effect on these little sort of nodal centers in the heart. Ischemic heart disease, if you've got some scarring if you've had a heart attack or whatever, it causes scars. You get scars, you get electrical disturbances. Swollen, if you get swelling, maybe valve problems and your chamber swell because it beat harder, again predisposes to these things. The big thing about AF is it's great now that the treatment, in the old days people had strokes from it, which was a terrifying thing, because when your heart's not beating, if your heart beats like that, nice and regular, the blood, you can imagine, just flows beautiful. It's like a lovely river just gently flowing, just being pushed along. But if your heart starts going into this arrhythmia, it stirs it up. It's like whipping cream, and then you get these clots in your heart. And when these clots form and they shoot out of your heart, well, it comes out of your heart, it goes to your brain, and that's when you end up with a stroke. So that's why it's very important if you get somebody, if you have AF, this irregular heartbeat, you get on the medication. There's two things: you try to convert your heart, they likely shock your heart in some cases to try and convert you back to a normal rhythm, but it only works. I find certainly probably the majority of people that have had it done tend to go back to AF. I found
That's the only thing that works for me. That's the only thing that works for me.
Did the cardioversion work for you? Did it?
That's the only thing that works.
Was it all right? But do you have you had it once, or have you ever had to have it?
I have it probably every 2 years for the last 20 years.
Seriously? Oh, well, and it worked well done, because a few people, most of the people I've seen, end up going back and just reverting back to AF and just get fed up with it. And
the only issue happens last time I went, they had to boot me twice. It burnt me pretty heavy.
Right. I remember in Ireland there was a guy farming for a big farming community, and he had AF, and he was just saving himself a trip to the hospital. He just used to go out when he felt it, he just grabbed the electric fence, shot, and there you go. It's just right now, you know.
Some more of that male behaviour.
With it? Oh, mate, this risk-taking behaviour, you know.
What's that?
Darwin Award.
It's another Darwin Award.
Yeah.
You've got to time it right there.
You would have to.
Can you speak a bit about sleep disorders and the options for, not disorders, but sleep issues?
Well, sleep apnea is again, it'll all go back to food, diet, and again, because with it, weight gain. Weight gain and sleep apnea are just hand in hand. The heavier you are, the bigger your BMI, the bigger chances you have of having sleep apnea. We used to call it the disease of the truckers and the taxi drivers, you know, because they would sit there, they would eat, and they wouldn't get any exercise, and invariably get sleep apnea. How you know you've got sleep apnea, or signs of it, it's very good. If you've got a partner or a wife, whatever, she'll tell you. You just say, you snore, and then you stop, and I start thinking you're dead, and then you start breathing again after 20 seconds, you just nothing, and then you go and you start breathing, and that's a sure sign you got, pretty sure sign you got sleep apnea. Daytime symptoms are you feel really, you're just tired for no reason. You know, you're sitting there in the car at the traffic lights, and you go, what was that about?
That's,
you know?
pretty extreme. I was kind of interested in like poor sleep and
just poor sleep in itself,
and the how should I say, the usefulness of sleep studies.
Maybe
that would be only for apnea.
Sleep studies, really all you're doing is you're looking for sleep apnea to see whether CPAP's going to be of any use to you. But I mean, are you just talking about people that have poor sleep patterns?
Yeah.
Yeah, well, I mean, as you get older, we sleep less. It's true. It's a fact of life. You know, you do not need as much sleep as you get older. The quality of sleep that you have, why are people not sleeping as well? I would say that a lot of it now, more so than ever, probably environmental issues with particularly, you know, I always say to particularly children or mums and dads, whatever, don't lie in bed with your phone, you know, don't have this bright light in your eyes, don't look at iPads, all this, Kindles and stuff, because there's this light being reflected into your eyes and it fills your body, it upsets your circadian rhythm. And then it just, because an awful lot of it resolves around a thing called cortisol, and what's meant to happen is when you go to sleep at night, your cortisol levels drop, and that actually brings you into a nice sleep pattern. If you get light stimulation, whatever, it keeps your cortisol levels up and then keeps you in that lighter sleep phase. So I always say to people, like, if you've got sleep issues, you try to work out why. I mean, if you've got problems sleeping, and it's come out of the blue, when you want to make sure it isn't things like sleep apnea type thing, or you want to make sure a lot of the time is it you know, people with maybe stimulants at night time, you know, so you might find somebody, and I know I've got relatives that, you know, go to bed at night and they've got the biggest mug of coffee on the way to bed. You go, are you serious? You know, and they go, yeah, no, I'll be all right, you know, going, you know, it's the stimulant, you know, or people drink Red Bull or alcohol or tobacco and stuff, anything that stimulates you. So we took a bit thing, if it's that sort of thing where it's just, you know, really poor, we call it poor sleep hygiene. You know, you just, you know, get rid of all the stimulants, you know, have your last, you know, anything, I would say have your last cup of tea, maybe, you know, 5 or 6 o'clock, that'll be the absolute latest, you know, coffee or tea, you know, try not to smoke at night time before you go to bed, try to relax. I always say if you've got a shower or bath, have a, you know, to relax, just have a shower or a bath, use the bed's only for sleep or reading, and if you're reading it's only a book. You don't use a Kindle or your phone or your iPad or whatever, because it's all that artificial light. So soft music.
Here's a question then: if you're talking artificial light from displays from keyboard devices,
yeah,
What about LED lighting for bedside lights and things? That's an artificial light
Well, it
source.
is. I mean, the only thing I could say in that situation is not something that's just it's beamed directly into your eyes.
Oh, right,
back
yeah.
your
So it's
retinas.
more diffuse.
Yeah, I think
Reflected
it's
light,
that it's just that flooding of your retina with all that light.
Yeah, because they've been big now on phones of having a dark mode on your phone, so that it lowers the brightness and the white light to a darker light, so that those that are viewing it at night and in a habit of doing that, they can then sleep properly.
Yeah.
Well, I'm guilty of what you're talking about, looking at a computer or reading something, but the Macs have this night shift.
They do it automatically.
And it changes the hue to a far less blue. I don't know if that's good or bad, but I think I'll stop it.
Well, I think it's the intensity of the light that's coming at you, because you're filling your brain into its daytime, to a certain degree, and then then you get this. You'll get a hormonal response from your pituitary gland to make you think it's time to get up, So it causes internal conflict for you. Other things are poor sleep. Again, a lot of times poor sleep can be emotional issues, psychological. And I always find a very easy way to work out. Somebody says I don't sleep well. I just can't sleep very well. I say, well, what happens? And generally it's, I'll go to sleep, but 2 hours later I'm awake like that. And I always say to them, well, what happens then? And they say, what do you mean? I say, well, what were you thinking about? Or what goes through your mind? And then invariably they say, oh, I was thinking about this problem at work and this thing, yeah. And I said, you're right, okay, so it's your brain's not turning off. It's an anxiety-related thing that you've got, and you really, again, that comes down to, learning to leaving your work at home or leaving your work at work. When you knock off at 6 o'clock at night, you got to leave your work there. You don't take it home. But again, these jobs, as you know now, again, 15 years ago, a job that took 3 people, now there's only 1 person doing it. Everywhere you go, and I hear that every day. Oh, there used to be 3 of me doing this job, and now they've got rid of 2 people. And I've been on my own doing this for a year, and I've got all these things I'm trying to do and organise and whatever, and I can't stop thinking about all these poor things. And
I don't know whether it's peculiar to me or not, but I've noticed that with the season we've had lately, with varying nighttime temperatures up and down, it's very easy to jump into bed and you have the same bed clothes as you had the night before. You slept well the night before, but you won't sleep well tonight because the temperature's gone up a little bit and you're too hot. Your body says that it's fine, you're just nice and snug in bed, but you're actually a little bit hot. And I've taken the blanket off, and in 20 minutes
you're fine.
I'm off and I'll stay off.
Again.
Yeah, just 19
your internal
degrees,
thermal clock's just not right.
Yeah,
just the little thermal clock's just not happy with the whole situation.
Yeah.
Well, I don't know. I always find as well, if I go on holidays and go up to Brisbane or higher than that or whatever, my sleep is never the same. Because you don't even pull the sheet back. You just lie on the bed and go to sleep. And I always feel I've got a lighter sleep. It's not as good as sleep. And again, it's probably this thing that your body's just a bit flustered. It's just not. It's not the right optimal temperature for what you like to be at. When you're asleep. So
I never have a trouble keeping warm or cool during the day, but my wife has a hell of a problem. Her body will not self-regulate the temperature, and if there's a slight change in temperature of half a degree, she's got to go and take a jacket off or put a jacket on, or find some warmer clothing of some description.
And she's not on any blood thinners, or she hasn't got thyroid problems or anything like that.
I'm the one on the pills.
Yeah.
But I never have any problems through the day.
Yeah.
But she's got to change gear, a dozen times a day.
Yeah.
Just to try and maintain her body. I say, what's wrong? I said, I'm hot or I'm cold.
And
I said, why? Nothing's changed. She says, I walked through a room and got cold or hot or whatever.
Some sort of it's obviously some sort of your thermoregulation comes from your pituitary, your thalamus glands, or thymus, hypothalamus. So it's something's going on in there with the regulation mechanisms.
Yeah.
Wow, what it is, I don't know. But who's the guy who's away? Anybody on blood thinners at all for like irregular heartbeats or recurrent clots or anything like that? Warfarin and stuff like that. Yeah. Do you feel cold as a matter of interest? Do you feel cold being on it compared to when you weren't on it?
No, but I suffer similar things to your wife. My wife probably, if the temperature goes down a couple of degrees, I notice it. If it goes, mainly when it goes up,
Yeah.
I'm very sensitive to taking the gear off.
Right.
No, but you're right. I'm on a, was it pulley or something anyway, it's a beta blocker.
Yeah.
Which is kind of like the same thing.
Yeah, yeah.
And like right now my feet are cold.
Yeah.
And I notice that my feet get cold.
Yeah. Well, these blood thinners is just because you know your temperature, the thickness of your blood controls your temperature as well. So if you thin the thickness of your blood by taking these blood thinners, you lose heat quicker. Yeah. So people, I find people, I always say people warfare and say, do you feel you notice the temperatures? And they go, oh yeah, I get cold easy, I get this. And it's just you're losing heat or gaining heat at a different rate than you did before. With the fact that your blood's thinner.
I get very cold at night in the feet. It'll take half an hour or an hour to make them feel warm again. Although the rest of them you can feel fine.
Just your feet?
Just my feet.
Take your socks on, man.
Oh,
well, you don't get chilblains. You don't have diabetes. You don't have any.
There's diabetes, and I'm on a beta blocker and things like that.
Just let you know, with beta blockers, that's a common side effect of beta blockers is cold peripheries. So just that's nightmares as well for some reason or other.
Yeah, my father had the same problem, but I don't think he was on anything like that.
Yeah,
he got it just hereditary.
Yeah. And a lot of medications is, I always laugh at a lot of the medications for, everybody really thinks your blood pressure must be up because you get a headache, that must be your blood pressure. And one of the medications which is really good for lowering your blood pressure gives you a headache, so which causes an awful lot of confusion. Everybody thinks, this is making me worse, this is making me worse. It says, no, your blood pressure is coming down, but it actually causes a headache. So sometimes the drugs can cause problems themselves, if you don't know. And if you look at a drug, it's terrible because you look at the leaflet.
Don't look at
I don't look at it. You can't. It's it's ridiculous because it will have every symptom on the and they're covering themselves. So if anything happens, and it was in the small print, it can make you you look at it, you go, and in particular the psychiatric drugs I find hilarious because it sort of says to treat depression, and then it says side effect depression. You go, how does that equate? Makes you feel suicidal. You go, well. They're just covering themselves, if somebody said, I don't feel better, and that, all right, we'll just put that in there, just in case, so it was in the small print,
But some of them even say possibly death.
Oh, yeah.
That's a side effect of life.
Life causes death.
Yeah, a mate of mine's been away getting treatment on the mainland, and it's been going on for months and months, and anyway, we were talking the other day, and he said that they fixed all the things that were wrong with him, and now what they're doing is fixing up all of the things that occurred because of the drugs. And it's taken longer to sort that out than it has in the original treatment. You sort of go, medicine.
Well, that's it. I mean, big pharma is it's a lot of it is not about curing things. It's about treating the symptoms of things, And I suppose it's it's better than nothing to a certain degree. But hopefully in the future we'll be curing more things than we'll be just ameliorating sort of thing of the symptoms of the side effects. But I suppose if it works and it helps, it helps. For the time being. But a lot of the drugs have potential side effects. And nowadays there's so many the big thing is now as we get older, polypharmacy, because as we weren't, like us blokes, when you think about it, like for females, I mean, menopause happens at about, an average menopause will happen probably about 47, 48 years of age would be the average one. And that's happening because in the old days, I mean, 200 years ago for somebody to live or a lady to live to 60 was pretty good, Our life expectancies have, despite all I've said tonight, our life expectancies have gone up, where now the males the average Australian male will live to about 79, and the average Australian lady will live to about 85. So they do get a bit further. The interesting thing, statistic I thought was quite funny was that a married man compared to a single man lives longer, right? But
That
a
can't be
single no, it's like married men live longer.
But it's the reverse.
No stress.
But it's the reverse. But a married lady lives less. If she stays single, she'll live longer. And so we obviously drive them completely and utterly mad.
Does that take into account their average length of life after he dies?
What's it after?
Well, she'll be single after he dies.
Yeah, well, that's it. And again, 55 or 50% of women they're outnumbering us anyway. But
Yeah.
but compared with obviously there's a trial on married against
Yeah.
single, and they do live longer. So I thought that was quite interesting. The other thing about for females as well, they don't have the exact same. The heart disease for men is the killer. It's not for the women. Estrogen is protected. So if you look for a female under the age of 50 with heart disease, is not you don't see it that often compared to males. But after 50, they start catching up with us because they've lost the protective effect of the estrogen, which is incredible. So it has that ability. Hence we tend to get on a whole more heart disease. And again, a lot of it's lifestyle. Again, smoking, diet, cholesterol, lack of exercise, weight, that sort of stuff.
Can you talk about arthritis as you get older?
Yeah. As you get older, arthritis again. As we get older. I'm trying to think in terms of arthritis. There's different types of arthritis. Now, the general one that most of us get is degenerative arthritis, which is just osteoarthritis, where your joint is just starting to wear out. The lubricant and the cartilage in the joint is just slowly but surely wearing out, and you start getting this thing where bone starts rubbing on bone, and then what that causes these cysts and bony growths, and you get these horrible arthritic processes around the bone, and you lose the mobility, and then you get pain, and you end up with a hip replacement or a knee replacement, and that's osteoarthritis. People say, how do you prevent it? Again, what's the causes for it? Obviously, things like the major joints that you get arthritis in are osteoarthritis, or your hips and your knees, and then your fingers. Again, you can imagine, because overusage, you're using your hands an awful lot during your life. They're hardly ever static, Again, your hips and your knees are major weight-bearing joints, so they're the ones that are getting pulverized day and night, and particularly if you've got a heavy manual job or whatever. So they just wear out. Some conditions may predisposed you to arthritis. And you might have heard of a thing called hip dysplasia. If you haven't been picked up, and you're born with it, basically your hips just aren't quite in the right place. Yeah, and if it's not picked up at birth, when we see babies just are literally a week old, they're examined, the paediatrician will examine them, but one of the tests he always does is it's called the Ortolani's test, and what he does is he'll take one hip at a time, and he puts his finger behind their sort of the sort of knob of the femur, and then he'll just try to move it right out 90 degrees with his finger underneath, and trying to feel for a little click in the hip, as if he's popping the hip back in. Now, and he does with the other one. Now, if he can feel a wee click, that's a sign that hip joint's not right. It's got this dysplasia, and if you pick it up then, you're going to be fine. But if that's left, you grow up with this hip not being unstable, not properly in the joint, and that predisposes you then to arthritis. So when you hear people getting hip replacements in their 40s and their 50s, and you think, oh, you're not that old, the chances are they've had this diagnosis at birth. It was a condition that should have been picked up at birth but wasn't, and it's just worn out prematurely. But again, knees and stuff like that's generally a sign of just you've just knackered knees, and you're just worn out. Things you can do to protect your knackered. Well, again, it all comes weight. Obviously, if you're not carrying weight, you've less chances of getting arthritis. But the other things you can do is, people talk about things like lubricants, natural lubricants, like to ingest a lot of fish oils are very good. There's a thing called glucosamine chondroitin, which is basically ground up crustacean shells, and it seems to have an effect on the joints. It helps. Turmeric is another good, just natural thing that helps joints. And then they talk about diets that are low in acids. A low acidic diet. If you've eaten a lot of acidic food, it tends to sort of have an effect on your joints. So these are the sort of other things that you can do. And then of course our great friend, what we all love, is our anti-inflammatories. They're great. They settle down pain. Your Mobics and your Celebrex.
Too.
What's that?
They can be hard.
Well, they can. I mean, they're associated with strokes and heart attacks as well, but not the bad ones haven't been taken off the market, you know, that we know of so far. But you've got those ones which will help. But then you've got the other forms of arthritis, which are the nasty ones. You know, you've heard of the rheumatoid arthritis. People who have psoriasis are prone to these forms of arthritis as well. You've heard of SLE, this lupus. You can get joint problems with these. These are nasty ones because these aren't wear and tear. These are where your body starts eating itself. They're called autoimmune disorders. Yeah. So, and those are really nasty, and those are the ones you don't want. I mean, if you have a choice between just a knackered joint or these ones, you take the knackered joint because at least you can just replace it. But these ones they tend to be systemic. They tend to be all over. You've seen people with rheumatoid arthritis in the hands. The fingers are almost bent in those directions, and it looks really nasty, and it's really sore. And the medications for it are a lot. They're things to try and knock off your immune system. So you're walking around with a sort of only a half an immune system to try and stop your body trying to eat your own joints, basically. And they're nasty drugs. You know, well, they're not. They're good drugs, but they mean, you know, you're maybe a little bit more prone to infections and stuff like that. And steroids they're on a lot of steroids, and you know, steroids predisposes you. Steroids are a great drug as long as you're only on them for a short period of time. If you're on steroids all the time, you see people that have got asthma or something that's taking steroids. You see them putting on weight. You know, the face blows up. You know, they get blood pressure, diabetes, all these sort of things, and it's because that's the horrible side effects of steroids. So, you know, so really at the end of the day, osteoarthritis is the lesser of the two evils if you get, you know, at the end of the day. And again, you get arthritis in joint. If you've got an injury, a lot of sportsmen, I mean, if you talk to a sportsman, you talk to a good AFL player or rugby player, and they're 45 years old, either they'll have knackered joints or replacements already because the injuries have just caused so much inflammation and damage in there that the joint now is just bone on bone for them, you know. So that's okay. And then knee replacements, hip replacements, very good. A hip replacement now, they've changed. They used to do it in the old days. You probably saw they used to see the big slice up the side, and they've stopped that now. The actual slice is front of it's called an anterior approach. And what's happened there? It means now there's less chance. When they did it into this muscle here, they used to get one of the problems where you get these things called posterior dislocations, and your hip could actually dislocate, and then people end up in the hospital getting relocated. Now since they've started going in the front, because they don't damage that big muscle at the back, it gets protective, and there's very few you get sort of dislocations of these joints, which is good.
But you only get 10 years out of it.
No, 25 now. 20 a good hip joint.
Increase the warranty period.
A good hip joint now. You get it well done for you. It should be 25 years. Knee and hip joints are good. Knee joints, I don't know if anybody's had a knee joint replacement. They're very good, but the post-op recovery takes a lot longer for it. It's just to get the movements back. I find 6 weeks before you see people even have a 90-degree bend in them after. And there's a lot of physiotherapy involved. Hip joints, everybody seems to be up and running in 2 or 3 weeks, you know, but the knees are a bit more problematic. I like joints as well. I mean, there's people doing these. You can have your joints in your neck replaced. You can have like lumbar spine. You can actually put artificial discs in now. It's incredible what they can do.
I had a relative go in for a knee joint replacement 6 months ago, and she was expecting to be not doing much for the first week, in bed just looking after things. Oh no, they had her up the day after.
They do.
And she was at home within the week.
Yeah.
And had an amazing recovery.
And she wasn't really complaining a lot at 6 weeks. She was fine. Like it was back to normal. Sort of
Yeah.
thing. Well, that's amazing because all the ones that come through to me, I just find it's I always
it's taken her a while to get rid of the lip, but she's improving much quicker than you would expect.
And you're probably wondering why everybody's out of hospital so quickly after all these major operations. Because number one is they don't want anything happening on the watch. Yeah, well, it's a few things that they want to get in, get the next one in. But the other thing is, the longer you lie in bed, the more chances you have of having a problem, like a clot. You know, so that's why they, you know, much against what you want to do. They want you up and walking around and doing things. So at least your circulation's up and going, so you don't shoot off a pulmonary embolus or get a DVT or something like that. A lot of people, when you go in a hospital, have you been in? You getting injections in your abdomen. Those Clexine injections are doing everything to make sure you don't get a clot when you're in the hospital, because you're not doing anything. So that's why they do that. It's all about statistics. They don't want anything going wrong when you're there. If anything's going to go wrong, you might as well be home.
Yeah.
When it happens, it looks better for the hospital staff. I'm being a bit facetious, but it is good to get the people up and about as well. Anything else?
Statins?
Statins, yeah, got a lot of bad press recently. My personal feeling on statins is they're good. I certainly seen since they introduced. I was around when they first came out. I can remember for everybody that had a heart attack. This was back in Ireland. Our incidence was about probably 50% of people had a re-infarction or a re-heart attack within 6 months of their first, and then statins came in and that disappeared. I didn't see people coming back with another heart attack. So the only thing that changed was statins. So I personally think they're good. They do have the odd side effect. People get this thing, it's called a thing called rhabdomyolysis, which is you get this muscle aches and pains, and I've seen that where it's like inflames your muscles a bit, and it can cause a bit of headache and nausea and stuff like that. But at the end of the day, if it was myself and I had a heart attack, I'd be happy enough to take the statin.
But you wouldn't take it prophylactically, would you?
Oh no, I wouldn't take it. Oh no,
for high cholesterol?
For high without a heart attack.
Yeah.
But I think for if my cholesterol was high enough, your cholesterol, it's not just dietary. Cholesterol is probably about 70% of it's genetic. So if you went out, if you had a high cholesterol and I said, right, you're eating salads, leaves, you're going to eat, lettuce for the next 6 weeks. That's all you're going to eat. Your cholesterol will drop by 25%. Okay, that's it. And it doesn't matter if you don't eat at all. Starve yourself, it'll still say.
So what do you consider high?
What's that?
What do you consider high?
I would say, well, the guidelines now is a cholesterol over 6 would be considered a high cholesterol. A few years ago it was 7, but they keep bringing down the guidelines on them. If you've had a heart attack and you've got diabetes, then it goes even lower. They say it should be less than 4.
Yeah.
So that everybody tries it. If you've had a condition or a cardiac event, you talk to your cardiologist, your GP, and he'll always be aiming to get your cholesterol down to 4, or less.
Yeah, because my mother was saying I'm high, and doesn't matter what I do, like I haven't eaten butter or anything for years, and it's always been about the same. And when they say you should get it down low, you say, okay, tell me what I should do.
Well,
and you go tick 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 tick, and you go okay next, and
if people come in to me and they're overweight and they don't do any exercise and they're not looking after themselves, I would say go away and look at your diet. We'll check it in 6 months. To see can I get it down 25%, and then we'll see where we can go from there.
Yeah.
There's other drugs you can use besides. statins are the latest. They're the third rollout drug for cholesterol. There was other ones before that, which were fine. They weren't bad, but they weren't as effective at getting your cholesterol down. They were called fibrates, and they're a bit out of fashion. You might have heard of a drug called Lipidil, and that was a fibrate. But now the ones that you hear about now are Lipitor and Crestor. And these are the statin ones. And then the other was one called Ezetrol. Is another one that worked in a different way, and anybody that can't tolerate statins or don't like statins, we try them with a thing called Ezetrol, which works in a completely different way. And nicotinic acid is another one that you can lower your cholesterol with as well. So there are other ways around it if you didn't want to try a statin. And then there's natural things, stanols and sterols that you can add. It's an additive you get from the naturopath. You add it to your cereal and whatever, and it's just a natural vegetable extract that helps bring down your cholesterol. Krill oil brings down your cholesterol as well. So there's other ways around it. If people don't want to try statins, there's things you can try, and it just means it's a bit alternative or complementary as well. But it does seem to work for some people, not as effectively as the statins. The statins they lower your cholesterol. There's no doubt about it. They pull it down very quickly. But yeah, some people just can't tolerate them. But I do. If I had a heart attack, I would, and somebody said to me, "You've got high cholesterol." I would be happy to take a statin. There's a lot of other things I wouldn't be happy with, but statin I would be. But I wouldn't be taking just. There are people out there that think, I'll just take all these things just even though everything's good, you know. But you do need some cholesterol, you know. You're not meant to not have cholesterol. It's there for a reason, you know. But just high ones, it tends to coat the inside of your arteries, because it just makes it's like a fatty type material. Yeah, it's just gummy, yeah, but it just sticks to the inside of your arteries and it gets stuck on there, and then it just can build up. Then you get red blood cells and bits getting bodied in it, and before you know it, you've got a thing called a thrombus, you know, a clot building up, you know. So you don't want that. And I mean, the big thing and heart disease, smoking is the big one, you know. At the end of the day, it causes damage to the entire. What it actually does is it damages the inside of your arteries, and then what happens is you get clot formation in it. It's not, and that's how you end up with a heart attack from the smoking. I mean, if there's one thing you shouldn't do, and if you had 10 things that you didn't want to do, or if you were doing all the wrong things, but you could only give up one thing, I mean, the one thing would be smoking, you know, because it really reduces. It's the bad boy of them all, you know. It's just it's involved, even bladder cancer. It's involved in, you know, besides strokes and heart attacks and lung cancer and emphysema, you know, bronchitis, you know, it causes cancers, you know, lung cancers. It causes cancers as well, besides your lungs. So it's a real nasty one.
Hey, you were talking earlier about skin cancer and sunspots, and so I go and see a dermatologist once a year, and they have this so-called what is it, head-to-toe check?
Yeah.
And so it's just more out of curiosity, wanted to know how do you get spots, say, on your feet or even under your feet?
Well, yeah. I mean, majority of skin cancers are related to previous skin damage, you know, which is obviously through UV radiation. So the majority, 90% of cancers you'll see will be on your face, your scalp, you know, side of your neck, top of your shoulders, top of your back. That's what the majority are. But it doesn't always work that way with melanomas. The melanomas can, for some reason or other, can pop up anywhere. They can even pop up in your actual nails, you know, on your fingers or your nails off your feet, and no rhyme or reason as to why. You know, it's not sun exposure. It's killing them. So I don't know the etiology of why it happens, but yeah, we have seen people with ones on their toes. In fact, a very famous case was, you know, Bob Marley, the great singer, and he got a melanoma on his toe, and he was Rastafarian, you know, the reggae singer, and and there was their religion said that, you know, you should never have any cuts. You're not allowed to. Your body cannot be cut or contaminated by a man with operations as such. So they basically told him, if you take your toe off, you'll be fine. He wouldn't do it, and he just got riddled with metastases, you know. So, but you do. I don't know why. I don't know the etiology of why you get melanoma, but that's what they're looking for. They're not looking. The ones you get on your face are generally things called squamous cell. Your sunspots are called solar keratoses, and they can change then to SCC, squamous cell carcinomas, and basal cell carcinomas, and they tend to be just locally spreading. You know, if you don't do anything about them, it's just the operation for getting rid of them is going to get bigger and bigger and bigger for you. And I have seen ones that, you know, people have had to have, you know, an awful lot of their skin removed, you know, and flaps done just for these SCCs, but they generally don't metastasize. You know, they just sort of locally grow, but it's the melanomas.
Yeah, with those, if you catch them early, you can actually kill them off by freezing them.
Yeah, you can, but the melanoma, you want to, if you've seen it, you've probably seen people that have had a melanoma removed, and you go, you know, the melanoma itself may be only maybe, you know, half a centimetre across, but when you actually look at the operation they've had, they've had like the margins of like 5 centimetres just to make sure. That's how scary melanomas are, because they are, once they metastasize, there's no turning back. You know, so you want to make sure you get every cell with them possible, and they're really nasty. You know them to look at. It doesn't look like a normal mole. It looks like it almost, you can see they're almost like they're like almost festering when you look at them. They're dark and they're black and they're very ragged looking. There's no, you know, they're not a nice circular mole sort of look or oblong, or they're just all raggedy and horrible, and you just know, you look at them and you go, oh, that looks nasty, you know, it looks angry. and but again, painless. You know, and that's the problem. That's the problem with cancer. Cancer is interesting because everybody worries about cancer. Cancer is painless. So this is the fallacy. Everybody thinks cancer. It's the effects that the cancer has on the areas that it is causes the problem. So if you get a cancer in your brain tumor, it's the effect of the pressure that it causes that gives you the headaches and the blurred vision and, you know, the unsteadiness in your feet and the nausea. It's because it's pushing on good brain tissue. So when you get the operation, you get it removed, all those sort of symptoms tend to resolve. Again, it can grow back again. The same if you get bowel cancer. It's not the cancer that causes the problem, it's the fact that it obstructs you. So you get constipated, you get change in your bowel habits, you know. And it's no symptoms, so you're feeling sick from the fact that you're not being able to poo properly. You know, it's the pressure effects of it all, because cancer itself is actually, the tumour itself is just a painless thing. So you know, it's the effects it's having on the organs around it, or if it grows into a blood vessel, I mean, then you'll bleed, you know, or these sort of things, or grows into a nerve or something, it's going to irritate the nerve and pressure the nerve. So it's the effects it causes around it, if you know what I mean. Again, but blood cancers are different because they're actually cellular than your cells, so you get different symptoms from lymphomas and leukemias and things. You get tiredness and nosebleeds and, you know, weight loss and fatigue and all that, so which are all a bit different. But anything that locally grows, it's the surroundings that are giving you the symptoms, if you know what I mean. Right? Anything else?
Well,
it does very well. Look at the time.
It's just been a very long presentation.
Oh, that's right. I enjoy that. I hope it's been of some benefit to you.
Yeah. Thank you.
Well, thank you very much.
Yeah, and I'll have to come up here some night and see how the ham boys do it all up here. I think this is very interesting. Yeah. Do besides yourself, Warren, any of the guys here, do you come up here and use the ham station here? Do you, or do you got your own at home?
All got home rings.
Yeah. All right. Okay. I just mean, yeah, ham radio to me is something I don't know very much about. You know? It's just 10-4. We've got a convoy. You know?
You have to get your license.
So you have to have a license to do it. Yeah?
Oh yeah, it's an exam.
Well, why do you need a license for it?
Because of the range of frequencies, the power that we use, the modes of transmission.
Yeah.
While it's fairly well defined, it's also wide ranging.
Right. Okay.
And we could upset a lot of people very easily.
It's a regulated service.
So you don't want to cause interference, like if you suddenly...
So could you interfere with a police broadcast?
Aircraft or TV broadcast or whatever? Just
if you didn't know what you were doing.
Yeah. And I take it you can pick up you probably pick up all the police broadcasts anyway. You pick up Coast Guard broadcasts and stuff like that.
Well, the Coast Guard
UHFCB is all pre-calibrated on certain frequencies.
Yeah.
You can change the number on the setting.
And you can hear
our dials are all variable.
Right, okay.
And they can wander.
Right, okay.
You've got to know what you're doing.
Right. And are you allowed to? I mean, could you tune into the police and quite happily sit there listening to their broadcast all day?
No.
Will they be able to
They're
detect
encrypted now.
Yeah, they're different.
Oh,
Up until probably, 10 years ago, they were all over.
Oh, wow.
15 years.
And the service that you get is a privilege.
Right.
It's not a right.
Yeah.
Right. So